Hello, my name is Sharon Best. Welcome to APP2APP virtual lectures. We're so happy to have you. Tonight's lecture is on primary progressive aphasia, diagnosis, and bedside testing. So I'm going to have three objectives. The first objective is to teach you how to correctly diagnose PPA, to recognize the root criteria, and then to recognize the criteria for the three different variants: Logopenic PPA, Semantic PPA, and Non-Fluent Agrammatic. We're also going to help you learn how to optimize bedside testing to help you differentiate between these three. We're also going to very briefly correlate the neuropathological and imaging features associated with each. So diagnosing primary progressive aphasia. We first have to understand that PPA is a group of neurodegenerative diseases that are characterized by prominent language impairment that occurs at the onset of the disease and through the initial phase. We would also expect our patients would have a relative absence of cognitive, behavioral, or motor disturbances. So there's going to be a two-step process. First, we're going to recognize root criteria, and once the patient meets that, we're going to then learn how to recognize the criteria for the different variants. So Marcel Mossalam is a neurologist from Northwestern University who was the first neurologist to describe PPA as a distinct syndrome in around 1982. I had the privilege of hearing him speak, and he explained that if you understand the meaning of the name, you'll already know the root criteria. So primary language is the primary or first symptom to present. Progressive, the language deficit will be progressively worse over time, reflecting that underlying neurodegeneration. And then aphasia, that he very succinctly and simply defined as an impaired usage or comprehension of words. So the patient must have primary progressive aphasia. Now there's exclusion criteria. Obviously, the symptomology should not be better attributed to another medical or neurological disease, nor to another psychiatric disorder. And as mentioned, we would also, the primary presenting symptom cannot be episodic memory or visual spatial symptoms. With episodic memory, we think of more an early onset Alzheimer's or late onset Alzheimer's. And also visual spatial, our top differentials might be a posterior cortical atrophy, one of the variants of AD, or dementia of Lewy bodies. We would also expect that that primary presenting symptom was not a behavioral symptom. So in such cases, we might be thinking more behavioral variant FTD or behavioral variant AD. And I put this little asterisk here that I think most neurologists would agree that we wouldn't expect that patient to present with Parkinsonian signs and symptoms at the onset. If they did, our differentials might be progressive supranuclear palsy, multisystems atrophy, cortical basal syndrome, or ALS. Now, we'll note that progressive supranuclear palsy and multisystem atrophy actually have a very high correlation with one of the PPAs, the non-fluent agrammatic type. Now, Maria Louise Gorno-Tempini is a neurologist from UCSF who published a very nice article in 2011. She had some very organized tables with the root criteria and the criteria for the variants. So this is her table for the root criteria. And I won't belabor this slide because it's everything I mentioned. She just has it organized in a slightly different way. Now, the criteria for the variants. I first want to point out to you that the logopenic is very often, but not always, driven by an Alzheimer's disease etiology. In other words, the underlying proteinopathy is amyloid plaques and tau tangles in the brain. Whereas semantic and non-fluent agrammatic are both more frontal temporal dementias. With semantic PPA, the most often, but not always, proteinopathy is a TDP43. Whereas with the non-fluent agrammatic PPA, we have different types of tauopathy that occur most often. Now, the first bullet here is the core criteria for logopenic PPA. It must be met. The patient must have both impaired word finding, so they're searching for words, and impaired sentence repetition. Now, in reality, all of our patients may have problems with word finding, including our typical Alzheimer's patients. However, so from among the PPAs, the one criteria that would really sort of nail this down is that sentence repetition is impaired. So these patients have an impaired phonological loop, which means when you ask them to repeat a sentence, a normal, healthy person will hear that sentence, they'll say it inside themselves, and then they'll be able to give it back. That is going to go through a process that we call the phonological loop. So when that loop is impaired, the patient will have a problem doing that. Now, there's supporting criteria that the patient may have phonemic errors or phonemic paraphasias, which means they may say a non-word when they're trying to say a word. So smoil might come out when they're trying to say smile. Now, in reality, phonemic errors or semantic errors may occur in any of these PPAs, but this is one of the supporting criteria for logopenic. So let's just jump down here and look at the semantic paraphasias that may occur with a semantic variant. And again, you can see phonemic or semantic really in any of them. So the semantic paraphasia, in contrast to the phonemic, is when the patient says another word that's a real word close to the target word. So they may want to say desk, but table comes out. Now, one of the core criteria for semantic is that the patient must have confrontational naming, impairment, and impaired single word comprehension. Now, a very easy way to remember this is to remember that this patient is going to have lost those words from their dictionary. So again, in reality, all PPA patients will have impaired naming tests. But this one, we're going to be able to tease out that that word doesn't exist there anymore in their mental dictionary. And we can do that a few ways. So we can say to them, we can show them some objects like a screwdriver, and we can say to them, can you name this? Now, someone with a word finding problem may have problem getting this out, but then we can say to that person, can you show me how you would use it? And if they can pantomime using a screwdriver, then we know they know what it is. So if they're unable and they look confused, perhaps this word has been lost from their dictionary. And we can do that with other objects around the room. We can do that with objects that are written on a pen and paper test that they're looking at, or in virtual, we can show them that on a slide. Also, we can ask them to read words that are irregularly spelled. So if a person I have 6 words in my head using the mnemonic pay big. So pay for pint, A for ache, Y for yacht, B for bargain, I for aisle, and G for guide. So these words are spelled irregularly. So if someone has lost them from their dictionary, they may revert back to their phonemic knowledge. So for instance, the word pint has a long I, and we're taught that long I's typically have an E on the end of the word, but pint doesn't have an E. So they may revert back to their phonemic knowledge, and they may read that word as pint. So we'll talk a little bit more about that later. Other supporting criteria for semantic variant is dysgraphia, an inability or a decreased ability to write. And we've already mentioned the semantic paraphasias. Also, the semantic variant has a relatively significant correlation with emotional liability. Now, looking at the non-fluent PPA, these patients must have either or of these first 2 bullets. In contrast to logopenic and semantic must have both, non-fluent agrammatic only needs to have one of these top bullets. So agrammatism is an abnormal syntax or abnormal sentence structure when they're talking. So they may leave out vowels or endings. And they also may have abnormal prosody of speech. So most of our speech has rhythm that goes up and down, and we have different intonations. Someone who has abnormal prosody may speak in a very monotone voice, or the patient may have apraxia of speech. So these first 2 bullets are the core criteria that must be met for the variance. Okay, so apraxia of speech is different from agrammatism in that the person actually has an impaired planning and programming of motor movements to articulate words. So you may notice that the speech is very slow, or they may have some errors. They may be groping for words. Now, remember, all of these patients must meet the core criteria first. It must be primary symptom, progressively worsening over time, and they must have an aphasia. So remember, a supporting criteria for this non-fluent agrammatic is going to be that the person will have an impaired comprehension of complex sentences. And in that way, we're showing that they have an aphasia. We're going to talk about something called primary progressive apraxia of speech, where the patient has apraxia of speech, but they haven't lost any comprehension of words. So they don't have an impaired usage or comprehension of words, Marcel Maslam's definition of aphasia. So here's Maria Luisa Guarno-Tempini's nice table for the clinical variants. So it's a busy table, there's a lot to memorize, but the previous slide made it a little more succinct in that the core criteria is boxed out for you. Semantic and logopenic must have both. Non-fluent agrammatic only needs agrammatism or apraxia of speech. The purple stars are just telling you that it's not agrammatic, there's no apraxia of speech. So we know logopenic is not agrammatic, they don't have apraxia of speech, and neither is semantic, so you don't even have to commit that to memory. The yellow box tells us it's not semantic and they haven't lost their word dictionary. So we know that logopenic is not semantic, non-fluent is not semantic, so we don't even have to pay much attention to committing that to memory. But the red crosses are worth committing to memory in addition to the core features, which is what I've outlined for you on the previous slide. Now, primary progressive apraxia of speech is also a neurodegenerative disease, but there's no aphasia. The patient just has apraxia of speech. So this patient will have word naming will be normal, word comprehension will be normal. Now there's some confusion and controversy, as you can imagine, because with a non-fluent PPA, the patient either has to have agrammatism or apraxia of speech. So if they have just the apraxia of speech, you can see how there can be a lot of confusion or misdiagnosis between non-fluent PPA and primary progressive apraxia of speech. So how would you tease that out? You would check for word comprehension. You would check for aphasia. And you could do that by asking them to follow a 3-step command. That's something of a complex sentence. You can do that by picture naming or in some way discerning and teasing out that they actually know the meaning of that word, even though they may not be able to say it correctly. So there is some controversy in that primary progressive apraxia of speech should be a separate condition altogether or a subtype of non-fluent PPA. Now, Marcel Maslam also did a very interesting study back in 2008, where he found that patients with PPA had a very high association of having a learning disability in their past and or their first-degree relatives had a learning disability. So about 15% of patients with PPA were found to have a learning disability, and 30% of their first-degree relatives reported having one. So that means a problem learning to read or learning to do math, whatever. So comparing that to behavioral variant FTD, typical amnestic AD, and control subjects, you can see that there was much less incidence of learning disabilities in their pasts. So you may want to ask your patient if you think they have a PPA, if they had a learning disability in their past, or if their first-degree relative did. So this is your first Zoom poll. Which of the following is a core criteria for logopenic PPA? Surface dyslexia, inability to pronounce irregularly spelled words, impaired sentence repetition, the impaired phonological loop, speech with abnormal syntax, or a very slow, laborious production of speech. So hopefully you would all pick B, impaired sentence repetition. So remember, the core criteria for that variant would have to be impaired word finding, so they're searching for words, and impaired sentence repetition because they have an impaired phonological loop. Now, the speech with abnormal syntax would go with the agrammatism, so that would be non-fluent agrammatic PPA, and the very slow, laborious speech would be apraxia of speech, also going with non-fluent agrammatic PPA. Whereas the surface dyslexia, the inability to pronounce or read those irregularly spelled words, those patients might have lost those words from their dictionary. Let's optimize bedside testing. All right, so first we have to know the difference in speech and language. So speech, we understand now, is the planning and programming of motor movements to articulate words, whereas language is a usage or comprehension of words. We'll use Musselom's definition. Okay, so the first thing we're going to do when the patient walks in the room is we're going to have a conversation. So during that conversational interview, we should notice if the patient has agrammatism or apraxia of speech. So remember that agrammatism is the abnormal sentence structure. So they may be missing vowels or prepositions, or the tenses may be incorrect, or they may have that abnormal prosody of speech, rhythm, stress, and intonation. Whereas apraxia of speech is an impaired planning and programming of those motor movements. So think that that patient may have trouble moving their mouth or their tongue. The speech may be very slow, effortful, halting, or groping. All right, so we can test at the bedside for apraxia of speech by asking the patient to do something that we call alternating motion rates or sequential motion rates. We just ask them to repeat as fast as they can, pa pa pa, ta ta ta, ka ka ka. Sequential motion rates, pa ta ka, ta ka pa. We can also challenge them a little bit by asking them to say irregular words like caterpillar, artillery, catastrophe. We can challenge them even more by asking them to repeat a difficult sentence, like the wicked rhinoceros ran down the hippopotamus. And lastly, I've added this, that we can test for orobuccal apraxia. We can ask that patient to pretend they're blowing out a candle. There is something of an association between apraxia of speech and patients having orobuccal apraxia. They'll be unable to pantomime blowing out a candle for you. Now, say we notice that this patient had apraxia of speech at this point in time. How would we distinguish between primary progressive apraxia of speech and a non-fluent PPA? Because remember, the non-fluent only needs to have either agrammatism or apraxia of speech. So that's the next poll question. So we could A, test for surface dyslexia, the inability to read or regularly spelled words. We can challenge with AMRs, SMRs, and repetition of difficult words. We can check for comprehension of single words with a naming test, or we can check with comprehension for sentences. Of complex sentences. So hopefully you picked D. D was one of the supporting features. So that supporting feature would tell us that not only does the patient have an apraxia of speech, the impairment in motor and planning, or impairment of planning and motor movements to articulate words, they also have a comprehension problem. So they have an aphasia. So remember, they must have an aphasia to be the non-fluent PPA. Testing for that surface dyslexia is going to tease out if the patient has lost that word from their dictionary. So we're thinking semantic PPA with that. Challenge with the AMRs and the SMRs, we would expect both patients to have that because they both have apraxia of speech. So we've determined that, and we're trying to go the next step. So checking for the comprehension of a single word, it's really one of the criteria for semantic variant PPA, but it may be helpful for us because we're still going to pick up an aphasia if they have an unimpaired comprehension of words, which they may still. But the formal supporting criteria is going to be to check for comprehension of complex sentences. Okay, so now we're still going to be doing, we're checking for comprehension, and we're giving you a couple of ideas of of complex sentences that you can use at the bedside. So we can say to the patient, point to the ceiling. After you point to the floor, point to your ear, close your eyes and say, ah, it was the boy that chased the girl. Who did the chasing? So now let's say that during your conversation, we've deduced that the patient has no agrammatism or no apraxia of speech. What are we thinking next? Well, we're going to continue to listen and we're going to look for some of the other clues. So we're going to look for word searching, which is kind of like prolonged pauses and in speech. We also may notice circumlocutions, where the patient is using many more words than necessary to express themselves. This is often a manifestation of an underlying word searching. They're compensating for the problem. So the semantic paraphasias, remember we mentioned, is going to be replacing a related word, but it is a word for word. So in other words, they want to say fork, but they say spoon, or vice versa. They want to say desk, but they say table, or vice versa. We're also going to look for the phonological paraphasias, where they're saying non-words in place of a target word. As we mentioned, smile for smile, or kesk for desk. So now, say we notice word searching and circumlocutions for our patient. What are we thinking? So this is the next poll. Prominent word searching and circumlocutions are commonly seen in. Okay, so it says choose one and the best response. So the word searching is a criteria for logopenic PPA. It's not a criteria for the semantic or the non-fluent, even though we see it there. Okay, so here's your fourth assumed poll. You suspect logopenic PPA due to prominent word searching and circumlocutions. Which of the following bedside tests would help confirm that suspicion? You can choose one or more than one. Ask the patient to read irregularly spelled words. Ask the patient to repeat a sentence, or ask the patient to name several objects in the room. So your answer is going to be to ask the patient to repeat a sentence, because one of the core criteria that must be met for logopenic PPA is impaired sentence repetition, because they have that impaired phonological loop. Okay, so logopenic PPA, AD etiology is often, but not always, but most often. And that would be that amyloid plaques and tau tangles are driving these symptoms. The core criteria is impaired word finding and impaired sentence repetition. The patient cannot hold a sentence online. Note that circumlocutions are often a manifestation of word searching. We can look for that supporting feature that is formally the phonemic errors, but in real life, they may really have phonemic or semantic paraphasias. We also may want to evaluate for dominant parietal signs. Again, because we expect that that pathology is starting here and spreading this way. So this would be the dominant parietal lobe, the left parietal lobe. Most patients are right-handed. So that hallmark again is they can't hold that sentence online. So this is the way we would check, ask them to repeat a sentence. So let's take a look at, I'm not sure how old this gentleman is. I just found this clip on the internet, but he has a logopenic PPA. So I'm going to ask you to listen for paraphasias and tell me if they're phonemic or semantic. Okay, so this is a really fast clip. It's only a few seconds.
In the summer, they sell vegetables.
In the summer, they sell produce.
So let's listen again.
In the summer, they sell vegetables.
In the summer, they sell produce.
Okay, so you can see that he's having trouble holding that sentence online. He's having trouble repeating it. So we're guessing that phonological loop is impaired. And hopefully you noticed two types of paraphasias. One, he said subble for summer, and two, he said produce for vegetables, or produce for fruit. I have to go back and look, I'm sorry. Okay, so now how do we check for dominant parietal signs? Remember, we're looking for dominant parietal signs specifically in logopenic PPA because the area that is affected is going to be the temporal parietal. So it's posterior parietal and temporal. It will eventually spread and then spread throughout the cortex. So some of the dominant parietal signs that we can look for are limb apraxias. So we have an idiomotor limb apraxia, a transitive apraxia, and an intransitive. Idiomotor, you can say to the patient, with your left hand, show me how you would comb your hair, and they can pantomime that. With your right hand, show me how you would sign your name. We can, for transitive, T for transitive, T for tool. We can say with your right hand, show me how you would use this, and we present them with a tool or say a toothbrush. With your left hand, show me how you would use this, and we present them with another tool. Intransitive, I just think of T for tool. Intransitive has no tool. With your left hand, show me how you would wave goodbye. With your right hand, show me how you would salute. So now there is a syndrome, but you must have all four of these signs to have Gertzmann syndrome. It's a syndrome where showing that the left parietal lobe has an insult. It's acalculia, agraphia, finger agnosia, and right to left disorientation. So one of the reasons why you're checking limb apraxia by asking them right and left is one, because sometimes they'll have a limb apraxia on the right and not the left, but also you're checking for right to left disorientation. Now, finger agnosia can be checked a couple of different ways. One neurologist told me, hold fingers like this and just say to the person, move this finger on your other hand, and they would move the finger that you pointed to. And someone else had mentioned to me that you can just say to the person, move your right index finger, move your left pinky, etc. And agraphia, impaired writing. Acalculia, we test by doing different little calculations. So what testing would you have considered to rule out a semantic variant PPA? So here's your next poll. Okay, which of the following results in bedside testing would be particularly helpful to confirm a semantic variant? You may choose one or more than one. An impaired ability to read irregularly spelled words, difficulty in AMRs, SMRs, and repetition of difficult words, and impaired naming. So hopefully you picked impaired ability to read because we're trying to discern if that patient has lost that dictionary, remember? And reading an irregularly spelled word, they may revert back to their phonemic knowledge if they've lost it. They also should have an impaired ability in picture naming, because again, if they lost that word, that's going to probably be the score will probably not be normal. Now, the difficulty with the alternating motion rates and sequential motion rates, that goes with an apraxia of speech, that impaired planning and programming to articulate words. So your answer would be A and C. Now let's look at surface dyslexia a little bit better. So the semantic variant PPA patient have a classic MRI finding of anterior temporal polar atrophy with the left greater than the right. So what we want to check if we see this type of MRI or if we're suspecting this at the bedside is we want to check for surface dyslexia. Have they lost their dictionary? So there's my 6 words, pay big. So the person may pronounce pint as pint, egg as achi, yacht as yaquet, bargain as bargahin, aisle as isli, guide as good. Okay, so also again, has that patient lost their dictionary is what we're looking for. So we can do object naming. We can show them a pair of scissors. Please name the object. If they can't name it, we're going to try to tease out, is this a word finding problem or have they really lost it? So we can say to them, can you show me how you would use these? And they can pantomime cutting. We can also show them something like a stapler. They may not be able to find the word, but they may say something like used to put papers together. So, and then I've given you another example of a reflex hammer. Also, this is visual confrontational naming. This is from the PBAC, the Philadelphia Brief Assessment of Cognition. It was developed by some of the researchers at Penn. So this is part of the PBAC where the patient has to name 6 pictures. It starts with easier pictures and moves to pictures of less frequency that may be a little more difficult for them. So again, we would expect impaired picture naming, also called visual confrontational naming, for a patient with semantic variant PPA. But remember, we'll probably see an impaired picture naming with all PPAs. But this will be one of the core criteria that's required to be there for you to make that diagnosis. So now, again, we'll keep thinking, has that patient lost their dictionary? We can do another type of naming test called naming to description or verbal naming. So we can say, what is a green prickly plant that grows in the desert? What is an 8-legged creature that spins a web? What is a black and white striped animal that lives in Africa? So this naming to description is also from the PBAC. We can test the patient by asking them to name as many animals as possible in 1 minute. That's called animal naming. It's testing semantic fluency. We can ask them to name as many F words or L words in 1 minute. We would be testing lexical or phonemic fluency. And then we can also, there's something called the multilingual naming test, or MINT, and the Boston naming test. So the 2 objects here are from the MINT. The other 2 below are from the Boston naming test. We start with higher frequency objects, and then we move to lower frequency objects to challenge the patient a little bit more towards the end of the test. So now we're going to look at some clinical scenarios. So this is clinical scenario 1, and we're at the conversational interview. Okay, whoops, let's go back. Sorry. Okay, so this is a 64-year-old male. He's a retired cardiologist, and he has a past medical history of AFib, hypothyroidism, and depression. He presents with word finding and memory problems for about 4 years. So our job is going to be to discern which one came first, the language or the memory. So per his wife, he has a lot of trouble getting words out and ideas across. He searches for words, often substitutes the thingamajig or the whatchamacallit when he speaks. He continues to read the newspaper daily, and as far as she knows, he's comprehending as well as he always has. So he seems a little more forgetful, but she says not that much more than herself, and she thinks maybe it's normal aging. He's still driving and managing finances well, and he's not having any problems performing his household tasks. So during our interview, there's no frank agrammatism and there's no apraxia of speech noted. The patient did have prominent circumlocutions and hesitations and word finding. He substituted Jackson for Jefferson, so the hospital in Philadelphia, and he also substituted mooching for munching. So these, okay, it's an intended word, but it still is coming out as a word, and same thing. So these would be semantic paraphasias. Now, here's his bedside testing. Our thoughts are the bedside testing would focus on differentiating between logopenic and semantic because he doesn't have any agrammatism and he doesn't have apraxia of speech. So we've narrowed it down to 2 already. So remember, with logopenic, the hallmark's going to be that he can't hold a sentence on line. And then with semantic, the hallmark's going to be, did he lose his dictionary? And then we may want to check for the presence or absence of dominant parietal signs because that will lend us to the one that has the AD etiology, which is a logopenic. So in the bedside testing, he encoded 2 the first time we gave him the 5-element sentence, 4 the second, and 5 the third. So we had trouble encoding it and trouble with that phonological loop. 5 minutes later, he recalled only 2 of 5, and when we cued him, he had only 4 of 5. So there is a problem with sentence repetition. He was able to calculate fine. He was able to name knuckles and stapler. He couldn't name a reflex hammer when we showed it to him, but when we asked what it was used for, he stated hit knees. So he correctly pronounced pint, yacht, egg, yacht, bargain, aisle, and guide. And we went ahead and checked for dominant parietal signs. So he did have a right limb ideomotor apraxia. He had a right to left disorientation, and he had a positive finger agnosia. So this patient has dominant parietal signs. He's not having any trouble, doesn't seem like he lost his dictionary. So our MRI, we would expect to look like an MRI for logopenic PPA, which is going to look a little bit like an early Alzheimer's disease with that temporal parietal atrophy. In an Alzheimer's disease, we're definitely going to have those medial temporal lobes and hippocampal involvement. With a logopenic PPA, we may not have that because we're not having any memory issues. So looking at this MRI, if you remember some of the MRI lectures, we're at the level of the pons. At the level of the pons, we're going to look at temporal poles, right and left, and occipital poles. The poles look relatively full because if we're thinking semantic, we would expect to see a significant atrophy here in the anterior temporal poles, left greater than right. So now as we move superiorly, we're at the level of the midbrain. We can see we do have some hippocampal atrophy here, but remember this man came to us 4 years down the road. And by the way, when we were interviewing, we did tease out that language was the first prominent presenting symptom and memory came after. And you can see that language was significantly worse and memory wasn't quite that bad. So as we scroll more superiorly, we're at the level of the thalamus. And here's the operculum. We have a frontal and a parietal. Here's the insula. So we do have some more atrophy coming out that's showing on the left side as compared to the right side. And then as we move up one more slice, we can clearly see we have very chunky sulci here in the parietal lobes. So going up a little bit further, we have a very wide posterior cingulate sulcus showing here. We also have very widened atrophy here. So this patient really has some frontal and parietal atrophy to just confuse us, but that's kind of what happens, I think, relatively often. It isn't a perfect MRI. So here we have a posterior cingulate sulcus. So this tells us that this area here, and we have widened intraparietal sulci. So, this is an occipital parietal sulcus. The posterior cingulate sulcus is shown in the next slice. So here we have occipital parietal sulcus that's nice and wide. We have some widened intraparietal sulci. Moving a little bit more from left to right, as we do with our sagittal views, we can see the parietal occipital sulcus quite wide. We can see intraparietal sulci and parietal atrophy. This is the precuneus. And we do have that posterior cingulate sulcus that is just slightly wide, but not bad. And here on a coronal view, we do have some hippocampal atrophy. So he is left greater than right. Now remember, this patient came to us 4 years down the road, and remember that logopenic PPA is driven by Alzheimer's disease. So that's why he's looking more like an Alzheimer's disease with his MRI. So the Zoom poll 6 is going to be which of the following is the most diagnosis, or the most likely diagnosis. So yep, hopefully you chose logopenic PPA. So the etiology is most often, but not always, Alzheimer's. Pathology, amyloid plaques and tau tangles. The MRI, we expect to see a temporal parietal junction left greater than right atrophy out of proportion to the rest of the cortex. We may be looking too for posterior cortical atrophy, sometimes happens bilaterally, and we look for involvement of the posterior cingulate gyrus. Clinical scenario 2. During the conversational interview, this is a 68-year-old male with a past medical history of vertigo who presents with progressive language problems for 5 years. Per his wife, patient started out occasionally messing up words, so this was the first primary symptom. It progressed to where he would use unrelated words or wrong words. For example, he described a doctor's visit today as a seminar. He recently had more difficulty understanding her when she talks. She must speak slow and use very simple words. Memory doesn't seem to be much of a problem for him. Doesn't have navigational confusion when driving. Manages finances and household repairs fine. He's quite active. He runs daily and goes to the gym 2 or 3 hours a day, 5 days a week. and he's more easily agitated, and he used to be a very easygoing guy. He has no overt anxiety or depression. Now, during your interview, he has no frank agrammatism or apraxia of speech. He has prominent circumlocutions, hesitations, and word findings noted. He also referred to his dog as his animal. Now, your thoughts are, at the bedside testing, we're trying to differentiate now between logopenic and semantic because he's not agrammatic and he doesn't have any agrammatism. So we're going to, one, check to see if he can hold a sentence online, and that would be the hallmark for the logopenic. And we also may want to check to see if he's lost his dictionary, being the hallmark for the semantic. And then if we want, we can do a little more and check for the presence of dominant parietal signs. So during the bedside testing, we asked him to repeat John Brown 42, Market Street, Chicago. He got 4 out of 5, but really just had a semantic paraphasia where he substituted avenue for street. He was able to name 2 of 6 pictures, so that's not very many pictures on the PBAC. He was able to name knuckles and window blind, but unable to name stethoscope. And he was unable to articulate what it was used for. So he had only 1 of 3 correct in the verbal naming on the PBAC images shown here. And he did have a surface dyslexia. So he said Achi for ache, Yakut for yacht, and Isley for isle. So your question is, what would you expect to see on this patient's MRI? Temporal parietal atrophy, left greater than right, frontal temporal atrophy, anterior temporal polar atrophy, or none of the above would be a significant finding. You can choose one or more than one. So we would expect perhaps a frontal temporal, and we would expect an anterior temporal polar atrophy. This is probably going to show up first for semantic variant, and then we can notice probably some frontal as well. So here's this patient's MRI. This slice at the level of the pons for P for pons, P for poles, right temporal pole, left temporal pole. Look at the anterior temporal lobe. And as we move up, we have the thalamus, a little bit of the frontal lobe starting to come in. We can see a widened Sylvian fissure here on the left compared to the right. And we can also see some widened sulci right here. And as we move up a little bit, we have a little bit, the angular gyrus seems to be a little bit affected, but probably not that prominent for this patient. And as we continue to scroll superiorly, we're now up at the level of the ventricle, so we're above the temporal lobe, so we can kind of eyeball this and slice in half and take a look. Now remember, a normal aging will have a little bit wider sulci in the parietal lobes and the frontal lobe, but here we can see we have a little more widened sulci, and this is the anterior cingulate sulcus that's kind of wide as well. So here we have definitely some widened sulci, more on the left compared to the right. Seems to be affected almost going down a little bit into the parietal lobe. And on this particular slice, we can really see that left is more affected than right. And we have some frontal atrophy, and even we do have a little bit of parietal atrophy. So what is the most likely diagnosis? With clinical scenario 2. So remember, we put puzzle pieces together. We put the clinical history that we've been given. We put the MRI, and we also put the testing. So the biggest piece of the puzzle is the clinical interview. And the smaller pieces are the testing that should support what that interview is telling us, and the MRI. So the MRIs are not perfect, nor are they diagnostic. They just help to support, to lend weight to, or take weight away from our suspicions that we get from the clinical interview. So which of the following is the most likely diagnosis? Hopefully you chose semantic PPA because he had the surface dyslexia. He also had the impaired naming, and he had the MRI that had that super anterior temporal polar atrophy on that first slice. TDP43 is not always, but most often, the underlying proteinopathy. And again, I've just written out the MRI here for you that we expected to find. So the neuropathological features of PPAs. This was a very nice study. Again, you'd think I loved Maria Luisa Guerra-Tampini, but She happened to have done this study that was also excellent on the pathology of the PPAs. She had 69 patients with sporadic PPAs, 30 semantic, 25 non-fluent, and 11 logopenic. So starting out here, this is semantic variant PPA. You can see that the large majority of them had TDP 43 type C, whereas just a few of them had something called GGT, which is globular glial tauopathy. Just 2 of them had the Pick's disease, and 1 of them had a different type of TDP plus an unclassifiable tau. Take a look at the logopenic PPA. 100% of hers had an AD etiology, so underlying amyloid plaques and tau tangles. And the non-fluent, if I can bring your attention to this large red and orange section, remember we mentioned in the beginning of the lecture that the non-fluent PPA has a high correlation of the patient having a concomitant progressive supranuclear palsy or cortical basal syndrome. Well, the red is the cortical basal syndrome, and the orange is the progressive supranuclear palsy. So what we have in green is a little bit of AD etiology. What we have in blue is a TDP. What we have in pink is a PICS. And what we have in yellow is another tau. So in all, what we end up having is we have different types of tauopathies that we find in the non-fluent PPA with a high correlation of concomitant CVD and progressive supranuclear palsy. So this was a supplemental table that she published to that same study. It had many more, these are different studies that have been done around the world. We have a few in the UK, a couple in the US, 1 in Sydney, Australia. So out of these studies, they were all done on PPA patients to look at the underlying pathology on brain autopsy. So the yellow columns are showing you the type of proteinopathy that showed up in the different types of PPAs. And again, this is Maria's study that we just went over. So again, 100% of her logopenic were underlying amyloid plaques and tau tangles. And the large majority was found, and in the non-fluent PPA, the large majority was different types of tauopathies. In the semantic variant PPA, the large majority was a TDP43. All of the other studies really supported the same finding. Large majority of TDP all the way through. Large majority of different types of tauopathies all the way through. And of course, the large majority of being the amyloid plaques and tau tangles all the way through. I just did the more recent studies that were in that supplemental table. So in a summary, we have 3 types of PPAs. We have the logopenic, the semantic, and the agrammatic non-fluent. Logopenic is most often, but not always, driven by an AT etiology, underlying amyloid plaques and tau tangles. We expect that MRI to have a peak atrophy in temporal parietal junction, left greater than right, and posterior parietal lobes with the posterior cingulate gyrus involved. We know we have a core criteria that must be met of both impaired word finding and impaired sentence repetition. And what we think is that patient can't hold a sentence online. So we can test by sentence repetition, and we may want to add in testing for the dominant parietal signs. This will be our most important test with the most weight. Now for the semantic variant, FTD etiology, same as the agrammatic. The primary proteinopathy is the TDP43, and what we'll remember is this patient has lost their dictionary. The core criteria that must be met is impaired confrontational naming and impaired single word comprehension. But we're going to be thinking, has this patient lost their dictionary? So they'll have trouble with naming pictures, naming objects. We can check for surface dyslexia. We can look for the dysgraphia, and we can expect there may be an emotional liability involved. The MRI has that classic finding of anterior temporal polar atrophy, left greater than right, and we may have some frontal involvement. The agrammatic non-fluent PPA, the core criteria is the either or. either a grammatism, the abnormal syntax and or prosody of speech, or apraxia of speech, that abnormal planning and programming to articulate words. We can test at the bedside using alternating motion rates, sequential motion rates, repetition of difficult words or difficult sentences. We also want to make sure that this is not a primary progressive apraxia of speech and the patient has a true aphasia. And we can do that by testing for comprehension of complex sentences. We can also test for comprehension of words, but that comprehension of complex sentences is one of the supporting criteria. So the MRI has the peak atrophy in the ventrolateral portion of the frontal gyrus, shown for you right here. Insular involvement may be shown. And again, it's frontal temporal. All FDG PETs would have hypometabolism in the corresponding areas that we expect to find the prominent atrophy on MRI. There's my references. Oops, that happened, sorry. And there's our website again, so please come and visit us, and please come back for more. Bye-bye.